This week on the BackTable podcast.
There it was so obvious because there was no IR. So obviously we had to go talk to the surgeons, talk to the nephrologist, talk to the emergency physicians, explain to them really what is IR, what can we add. Same thing with reaching out to patients in Tanzania, saying we can do uterine fibroid embolization through the wrist. You don't need to have an open surgery. You don't need to have a hysterectomy. We kind of assume, because we went through all the training, that everyone should know what IR is. At least every doctor should know what IR is. But it's just not the case, right? So we really need to do more outreach to the community. We need to tell patients what we can do. We need to explain to other physicians what we can do, because we can really add so much. And it's really a lost opportunity if patients and other physicians don't know about our capacities.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a brief message from our sponsor.
For more than a decade, Reflow Medical has designed and engineered medical devices that respond to unmet clinical needs. The Wingman crossing catheter, with its unique extendable beveled tip and an expanded indication for CTOs. The Specs LP, created to meet the need for a low-profile version of the Specs shapeable support catheter, and the new line of core catheters that answers the call for a suite of effective tools to use in challenging PCI procedures.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast. Now, back to the episode.
Hello, everybody. Welcome to the BackTable podcast. My name is Isabel Newton, and I am really excited to have this opportunity to guest host this episode on Road2IR with my friends and colleagues, Dr. Janice Newsome, Dr. Judy Gichoya, and Dr. Fabian Laage Gaupp. The idea for this podcast came as my colleagues and I were talking with you guys in preparation for our first trip to Tanzania to volunteer for Road2IR and to film for Without a Scalpel. And we realized that this story has evolved so much since episode 104 of BackTable that Fabian did on January 4th of 2021 that we thought it was time for another one. But before we delve into all of that, I'd like to introduce our guests. Dr. Janice Newsome is an IR dedicated to developing innovative treatments and advancing medical education. She joined Emory University School of Medicine after 15 years of private practice in Virginia and is now an associate professor with a focus on health equity and improving maternal morbidity and mortality. Dr. Newsome is actively involved in SIR. She co-edits Techniques in Vascular and Interventional Radiology Journal, and she is a leader in the Road2IR Foundation and the training program in Tanzania to improve global health equity through education and outreach. Dr. Newsome is also a wife and a mother who believes in the power of hard work and service to others. Dr. Judy Gichoya is an assistant professor of IR and informatics at Emory University. Her career focuses on validating machine learning models for health in real clinical settings, exploring explainability, fairness, and a specific focus on how algorithms fail. She is heavily invested in training the next generation of data scientists through multiple high school programs, serving as the program director for Radiology AI Trainee Editorial Board and the medical students' machine learning elective. Dr. Fabian Laage Gaupp is an assistant professor at Yale University, where he specializes in men's and women's health, offering minimally invasive treatments for BPH and uterine fibroids. He is one of the co-founders of Road2IR. Road2IR is an international consortium led by Yale, Emory, Muhimbili University of Health and Allied Sciences, which is abbreviated MUHAS in Tanzania, and other institutions in North America and Europe. Road2IR has successfully established the first accredited IR training program in sub-Saharan Africa. In 2020, the program was awarded an RSNA R&E Foundation Derek Harwood Nash International Education Scholar Grant, and MUHAS was selected as the world's second RSNA Global Learning Center. The program now serves as a blueprint for partner programs in Rwanda and Uganda, aiming to bring minimally invasive IR procedures to more patients in East Africa and beyond. So guys, Road2IR is an incredible success story in bringing IR to East Africa, but also a story of how a group of people came together and turned a great idea into something tangible and impactful. It's truly remarkable, and I'm hoping we can explore how you turned idea into action. So let's begin with, how did the idea for Road2IR originate?
Should I start?
That's you,
Yeah.
Fabian.
All right. So it's a while ago now. So, thinking back, it was 2017. So I guess at this point, almost 6 years ago, when I went to visit Tanzania with my friend and mentor, Frank Minja, who was a neuroradiologist at Yale at the time. And so he took me to Tanzania when I was a second-year diagnostic resident. And my goal was to see what is the status of interventional radiology in Tanzania. So I went there and I met 3 really nice diagnostic residents, also at the time, second-year residents from Tanzania, Eric, Ivan, and Aza. And together we did this readiness assessment to see what is the status of IR, and if there is none, what can we do about it? And what we found essentially is that all of the pieces, or most of the pieces you need to do interventional radiology, are already in place. So there was a diagnostic radiology training program with up to 20 residents per year. There was CT available, there was ultrasound available, there was fluoroscopy available. But what wasn't available was the actual training. So that's when we decided to try to form a group and start interventional radiology training in Tanzania. And so the start of Road2IR is really a WhatsApp group. Ivan is the one that came up with the name. And so when I was leaving Tanzania and we were driving back to the airport, Frank and I were discussing what can we do about it. And we said, okay, we'll just try to really go full force ahead, and we'll try to start IR training in Tanzania. And that's what we did the following year.
That's amazing. Do any of you have something to add?
No, not really. I think that, FLG, as I will call him from now on, is a propeller rocket ship to any idea. So your question, is like, how does an idea become what we have right now? I think it was already a novel idea, a noble idea, an idea whose time had to meet a moment, and a moment met a man or men at the time. And then you had the hearts of the people that were there in Tanzania prepared, and that's how it got started.
That's amazing. What got each of you interested in global health to begin with?
So my journey to Emory is very different, and I actually went to medical school in Kenya. I grew up in Kenya. So I think, obviously, like many things that I've learned, in my last 10 years here in the US, it's mainly around terminology. I didn't even know what my daily life was what's called global health. But I knew that there was a lot of concern for physicians like myself living Kenya, but I had a passion to always do radiology and informatics. And so when I'd quite done a lot of work in global health around informatics work, but I realized that if you're not a physician, that you got or any form of clinician, you got too far removed from the real world setting. And so when I chose my specialty and I was thinking about my skills, I thought that the fascination, and even in my personal statement as I applied for residency, it was always how long it took to get access to care. So this felt like the best way to make an impact, although I see myself as not like, when you think about sometimes global health work, it comes out as mission work. But I just think this of myself as taking care of my family and making sure that my mother and a lot of my family still live in East Africa can get the best access of care, which remains a big challenge.
Yeah, I mean, I don't know that I have that much more to add, but I'm from Jamaica originally, and, I too kind of struggled with, the terminology global health, right? Because when you're doing what is called global health in your in your mind, before it was in this organized fashion in Road2IR, you're just doing what you can to take care of your aunties, uncles, families, wherever they are in Jamaica, and even in Eastern Africa or Sub-Saharan Africa. Some of my work in Ethiopia, in Israel, even beforehand, I didn't really consider that same terminology, global health. Is just, again, doing what we can do, not exactly at Emory or wherever you are, just somewhere else, but I've come to understand that it is not just mission work, right? And which makes what we're doing here, and we're here to talk about, so much more exciting, right? It is not just doing, helicopter mission work.
Yeah, very similar for me. I think, most physicians really have the goal of helping as many patients as we can. And the fact of the matter is that in Sub-Saharan Africa in particular, but also in many other regions of the world, there's just a really severe lack of access to care. And that applies in particular to radiology and interventional radiology. So for me personally, I just think that the impact that every single physician can have is very much amplified in these settings. And, I'm just happy to contribute in whichever way I can.
So you guys all alluded to this kind of tension between the concept of the missionary experience, kind of swooping in, donating something, giving something to a needy population, but it's not sustainable. And that's kind of the magic behind what you've been able to do. You are creating something that is lasting and that is going to catalyze real substantial change over time. So Fabian, in episode 104, which if the listeners haven't listened to this yet, you absolutely have to. It's fantastic. And it gives a lot of the background that we're not going to go over in this episode. But you mentioned that IR in Tanzania was like it was in the US in the 70s. And indeed, this has been a remarkable opportunity to develop IR in a calculated and intentional way. So having said that, where do you think it is now? And how do you think the benefit of hindsight has helped everyone get to where we are now in Road2IR so fast?
Well, so as I said, and in the prior episode, those early years in Tanzania were really required a lot of flexibility and a lot of patience also, because we didn't have access to all the resources we needed immediately. As I said, in terms of imaging equipment, most were already available, but what was not available in addition to training was really the disposable equipment. So we had to, really come up with ways to try to compensate for that. And in the beginning, when we started, it was really just very basic procedures. So mostly corneal biopsies, abscess drainages, nephrostomies, biliary drains. And it took time to then step by step get to a point that is, now much closer to what we have in the United States. So at this point, we're now almost 6 years after starting the program. We can essentially provide the full spectrum of IR with very few exceptions. So we're not doing Y90, but we can do TIPS, we can do TACE, we do pediatric IR, we do vascular procedures. So we've really come a long way. And the only way this was really possible is by a lot of amazing people investing their time. So all of the mentors that myself, Eric, Asa, Ivan, and all the other trainees that came after them have really made this possible. So we've had mentors like, of course, Dr. Newsome, Dr. Charles Sanika from South Africa. So many people from all over the world really invest their time and get the program to where it is now. So it's really been quite amazing actually how fast things progressed. And it's only been possible because so many people invested their time and their passion into this.
So what I'm hearing you say is that the fast forward button was really about good, strong mentors guiding this ship in the correct direction, which, as IR was sort of organically developing in the past, there were leaders, but, they were sort of making it up as they went along. So you have this opportunity to really intentionally choose the parts that are wins, right? And implement them.
Exactly.
I think that Fabian is also being very modest. And this is because if I had to ask all these people to travel, I would also feel the same. But I would say that really what was the path and just that evolution is really the passion and the belief in the very, very early mentors and the three trainees, Ivan, Asa, and Eric. For you, imagine for you to believe in training in something that you've never even seen, never even imagined, and to believe that you're going to actually spend time away from your family, make less money. You don't even have a catheter, you don't even have a nurse, you don't have a nurse navigator to call anyone for you, and to believe that the words of Fabian and the words of the early mentors, that they would see you through, I think cannot be underestimated. And it's that passion, even during the tough times that have been since episode 4 to now, including COVID and disruptions of travel, that have been, I think, that have sustained. It's really those three individuals. The other thing is also the frugality of, I would say, Fabian and really wonderful Diane, who should really be on. And this is Diane is Fabian's wife. And, how do you started off the episode saying, look, we got $100,000. Everyone, if you've traveled or gone to vacation just within the US, that doesn't take you a lot. If you looked at how many people were able to travel on that funding alone because of this frugality of Fabian, I remember him saying, Judy, the tickets are going up. And I looked on and it's like, it's $20. I'm like, Fabian, why are you stressing me about this? And it's just this passion and vision. And also realizing that Fabian still then was a resident and now is an attending. And we can't just let those things stand by. They're really the pillars that have made us to be in a place where we can even learn and redo things a little better as we're doing now.
Well put.
Yeah. And it's I don't know that I can add any more to, what was exactly said, but, if you get to start a training program from scratch, right? And you get to experience all the things from the US programs, you have to start thinking, what are some of the best of the things and what are some of the things that we really need to avoid, right? And you're giving yourself also some of that grace to be able to make some of the mistakes. Because let's be honest, like who would know in Tanzania if this is not the way it should go, right? We're doing everything from scratch. And the benefit, Dr. Isabel, from having some of the best lecturers, the best lecturers in the world. Like I could give a lecture on, whatever it is, but I would be looking it up and making it. But what we were able to do is to get the best of everyone in the world to come to Tanzania and teach their specialty to those people. It's like the most amazing faculty ever, to be able to do that. And it's not just, can you come, and the passion of Fabian and the passion of the trainees that's there. I want to point out one of the earlier attendings that traveled was Dr. David Prologo. And Dr. Prologo had not even had a passport. He had not left the United States for anything, not even for, putting his toes in the sandy beaches in Jamaica. He just have never left the United States.
No one goes to Jamaica.
Well, we will, wherever, he should go to Jamaica. It's a piece of heaven. But I digress. If you could think about, what would it take for someone to overcome their fear of traveling, it would take just one thing, and is an ask from a friend and a love for patience so much that would make someone go apply for a passport to fly halfway around the world in a different continent, in a country, to say that they could contribute and do anything, not because they wanted to go and treat one patient who had pelvic pain, but because he also bought into this idea that you can actually train people who would help many more people who would have pelvic pain, so that I won't have to make this trip again. That is unbelievable.
Thank you for telling that story, because I remember when you told it to me, it was so fascinating. And I do think that it is kind of the magic mix, right? You have people with passion, people with vision, but they also have to be doers. They can't just be imaginers. They have to be doers. So, Dr. Prologo going out and getting his passport, Dr. Newsome, you picking up the phone and calling in the troops. Fabian, your bravado to at your stage of training to be like, yeah, this is totally doable. Maybe it was just the ignorance of the youth. But and then Judy, I want to talk a little bit about your experience because you were telling me how you volunteered for Road2IR during one of the most daunting times, like the thick of the COVID pandemic. Can you tell us about that experience? And then maybe, Janice, you can speak up and kind of pepper that story as appropriate.
Yeah, so, when I introduced myself, I said that I came to Emory and I work for Janice. And the reason she keeps me really, except today when I don't have to help her with the IT problems, although you had her shame me about her laptop, is as an extra hand. But, this is just during COVID, as most of us remember. It was really, I think, IR specifically evolved to do many, many things, not just because of being abroad, but also, institutions rethinking how to make procedures safe, rethinking how to make our staff safe, when quite a lot of diagnostic radiologists actually were able to read from home. The technologists were in the hospital and leaned on IR, as always being the last stop. And in one of the days, our way of decompressing was really to take these walks on our campus and around the parks where we live. And, it was a weekend and we were just talking, and Janice was really sad, which is very hard to recognize. Don't worry, Dr. Newsome, I'm not going to shame you.
It's okay.
On audio.
Okay.
And she just came from her usual weekends. I think Fabian knows this. Every weekend, there's a big meeting about Road2IR. And she was really sad. And she said, look, our program is going to get shut down. And this is because Tanzania was not recognizing the, COVID pandemic. And so was, if you don't recognize something, then it's difficult to say that people understand why people cannot travel when you don't have COVID, And so, program at that point was in jeopardy. And one of our trainees who was not a Tanzanian resident was actually out of the country. And so there was a lot of desperation. Long story short, Janice was very sad and wondering what to do. And I said, it's home. I can go. This was before any testing, before any vaccines. And that was my first trip on Road2IR for 2 weeks. And it was an amazing time. And, as you know, there are many, many stories from that visit. But I would like to say that, even when we came back for the oral exam study, we came to graduate, which was my second visit, there was a lot of magic just because the people who had come and just rekindled that, figuring out how it could be safe for people to travel. It was just a fantastic meetup.
Yeah, and we can say that now in that it was successful, but it was very risky, right? So the university banned travel. There was no way to get anyone there. Poor Fabian is having a little PTSD for those moments, right? When we were having, just these calls and not sure what was going to happen. Ivan, Eric, and Asa were pretty sad because everything else was happening as usual in the university, right? But our program, our training program is dependent on these visiting teams. And I remember just saying, this friendship is born in adversity. And this is an adverse time. And how do we get our friends from all around the world now to jump in? And Dr. Gichoya said, without even thinking about it, I'll go. It's home. Okay, remember, there's no vaccine. We have a travel ban. And you'll find out that Fabian here runs a very tight ship, that he's virtually at every visit in picture form, right? So as soon as you land, you got to send a picture. As soon as as soon as you get to you got to send a picture. You got it, right? So then we had to come up with the strategy of how do we have Judy get there, but no pictures, right? There cannot be just an internal control. And knowing, Dr. Isabel, that, at any moment, at least from the university side, things could be tough, right? So then Dr. Gichoya would go, but who would be next? And, we just had to call on, again, that friendship. And I remember the second call that I made, and you'll hear people talk about Ian Wilson. I think they call him the area code now of Tanzania. I picked up the phone and said, who is not affected by COVID and or travel? These restrictions are not as difficult in our private practice world, in the people that own their practices, OBLs and ASCs. And I called Ian. I said, look, I need you, my friend, to go to Tanzania to help us to bridge this program. And, funny story, he'll tell it. He's like, sis, I'm there. I want to let you know that I'm talking to you from the prone position, because Ian actually had COVID right when I was asking him to travel. And, one way to look at that would to say, well, I have COVID now and I don't think I could travel. But he saw that as his opportunity. He's like, great, I'm next. I already have COVID. What can happen to me? Sign me up. And sure enough, I think Ian has gone back many, many times, probably not as many times as Fabian, but that deposit that was made. Dr. Sanika from South Africa, he says, sign me up. I'm there. Like, we got our friends that could travel, from Europe, sign me up. I'm there. So I would say that the adversity actually made our program richer. It made our program stronger. It actually even allowed our trainees to see where they were now starting to needing to act as attendings quicker. Just the same things that were happening in the US, right? Where, all of a sudden people were like, okay, you can put central lines, you don't need supervision, you could do that kind of thing. So we had an acceleration of responsibility of people recognizing their skills. And all the time, yes, it was a Rolodex of people, friends that you knew who could come in this time. I know that Fabian himself was keeping the ship of the trainees together. And what do I mean by that? Like, I'm making these plans with my friends and attendings, to get there. Fabian is making sure that people could go. But there are the subtle things about what was happening to the mental health of our people on the ground, not just the physicians, but the techs and nurses that had given up so much to do that. And here is where peer mentorship is supreme, right? Like, they would tell Fabian things that I would never hear because they saw him as their resident. They were both residents so resident to resident conversation was helpful. And I think when Dr. Gichoya was able to go and speak a little Swahili, like, she also was able to pick up on a few things that we couldn't get from abroad. So it wasn't just that we wanted to make sure that they were being taught what was in the curriculum. It was this support of the emotional distress when you have to now train in a place where the rest of the world thinks something is happening, right? And there it's no recognition. Like, we couldn't even say the word COVID on our calls, right? We are all wearing N95s and they're like, and what are we doing there? We were like covertly telling them, take the temperature of people who are your patients. Make sure you're not doing elective cases on COVID. Remember those days, Fabian? I mean, it seems a little laughable, like right now, write a list down. And they're also doing the reverse, Dr. Newton, like telling us the state of COVID in a different way, because we also got some upfront, close experiences of what happens when COVID is not recognized somewhere, right? So I didn't need to figure out what would happen in my hospital if we didn't wear masks and stuff. Like, I got a chance to see that right there, right?
Yeah, and this came from the leadership of the country, right? The president didn't recognize COVID. Can you just mention what that was? And
Fabian, that's you.
Yeah, I mean, like Janice was saying, I mean, it was just like a tough, there was just a big gap in how COVID was handled in different countries, right? We know that very much, sort of from, Canada on the, probably the strictest end to, US somewhere in the middle, and then to Tanzania where, really it wasn't even a topic. So sort of to make that work was really difficult. And we had some tough times, but I think what united all of us was that we knew that the need is just so severe, and we were just in the first year of the official training program, essentially, or a second year. And there was no way that we could stop at that point, because we needed to get that first class to graduation, because we knew if we don't do that, then the whole thing is just going to fall apart. And, of course, I mean, were we concerned about COVID? Obviously. But we also knew that so many IR procedures can just save lives, and that's a guarantee. And, could someone travel and get COVID and, potentially be in trouble? Yes. And we made very clear with everyone traveling that they have to be aware of that. And those were really tough times. And I'm really incredibly thankful for all the people that were mentioned that came through in those tough days. Ian, Charles, Judy. It was really, really incredible. And that then really established the belief that we can pull through. And then from there was just took off.
Oh, rocket ship. Absolutely.
For me, the story of Road2IR, one of the reasons why it's so deeply compelling is it recapitulates the story of IR in general. IR is a story of resourcefulness, of courage, of community. And you guys have taken that to such a level that you remind us how it's done right. And you inspire me of why I went into this. And, if I encounter some kind of roadblock, as I do, I work in government, how that's a small thing. And we are built to overcome these things. So you have done it so beautifully. And Janice, Dr. Newsome, and I want to mention, I did ask permission to call everyone by their first name at the beginning. You have served as program director for this training program. Can you give us a sense of its current status and where it's going?
Oh, that's amazing. So, of all the things you've said on my CV, besides being a mom and a wife, I think that serving in that capacity as the program director at MUHAS is one of my, highest achievements. And what that means to me is, clearly we could decide that we are going to just do procedures, but you've heard that how we had to actually put a formal training program in place. And no matter how much you want to just say that you're going to do a fellowship program, if you're doing it correctly, as Fabian, Frank, and myself had set this up at the very beginning, it involves the university, and it's a degree program in the university. So although it may seem to people that are going there that they're just doing procedures, there's an actual curriculum that is being followed that is a gradual curriculum of starting to do things, and not just for the physicians that are being trained, that they eventually have to pass written test and oral test, in stages, and then a formal oral exam, kind of the way we do our IR oral boards there. That requires some administrative work. Even though on paper I'm the program director, I could tell you that the work of being the program director of a program miles and miles away involves a lot of folks, right? So the making of the exam is, Fabian, Judy, asking lots of friends, looking at the exams. Our first year, the exams were all written, collected, collated. Even during COVID, when they needed to have their oral exams, we had oral exams via Zoom. We had board preparation exams via Zoom with Dr. Paul Sohaki at Duke doing the lion's share of preparing the trainees for that. The second year, we were able to graduate to a electronic platform, or the second class, an electronic platform. And here is where Dr. Gichoya is going to chime in and says, what does Dr. Newsome know about IT at all? And I remember both her and Fabian, they're trying to help with, the columns, where things go, all the IT portions of trying to put both a written exam together and an oral exam together. And I'm proud today to say that a part of our program, which is the capacity building and sustainability, isn't that we were going to remain in this role. And Dr. Baloa, who graduated last year, is already employee of the university, a professor at MUHAS. And this is just how funny things go. And I'll just leave Fabian to talk about, who that wonderful individual is, that now we're transitioning from me being the program director. Like, who would think that by next year, Dr. Baloa will be fully the program director at MUHAS for a program that he graduated from. And all of us will continue to serve in a formal advisory role there. I mean, certainly as it relates to the oral exam or the board's exam at the end, we will still have our, international faculty come in to do the oral exam. But I'm just super proud of that.
And so you kind of alluded to this, but how then has the role of the visiting teams of IR clinicians, nurses, and techs evolved as Road2IR has matured and this program, the training program, has matured?
Well, I mean, obviously in the beginning, nobody there had done any IR. So I very well remember the very first IR procedure we did was Dr. Douglas Sillen, who's my program director at Yale. And it was a biliary drain. And to even just get the case started took several hours. We had to look for an oxygen probe. We had to look for a blood pressure cuff. We had to actually kind of build the table because it was just a regular floor table. We had to find a little ladder and like a board to extend the table. So it was, it was a lot. But now we're at a point where someone like myself as a junior attending can just go there now and doesn't even have to scrub in, because we have our Tanzanian faculty who are amazing. And now visiting faculty go and they just scrub in when there's really a little trick they want to show or like something to help out. But the program is essentially independent now. And it's so amazing to see Aza and Eric and Baloa now supervising the next classes of trainees. And that's exactly what we wanted.
So the role then is more to facilitate more complex procedures and also teaching, right?
Yes.
While they're there.
Yes.
Yeah, and increasingly to support the people who've left, right?
Yes.
So there are new people who've left from our program who are in other places to support those new attendings.
Exactly.
Some in Tanzania and some outside of Tanzania, right? So to think about that, you've graduated now from its inception, a total of 10 graduates from 0 to 10, right? In this short of time, some of them who are remaining as faculty at the university to continue on in a formal, what we would call an academic center place, and some who are in more of a private practice type setting, right? They don't have trainees there, but still doing IR. One who is at a cancer center, dedicated cancer center, and of course, some that are outside of the country. And just in case this doesn't get mentioned anywhere, I want to talk about, just the diversity of the class, because it is intentional. And if you want to get something different, you have to do something a little bit different. And so in our first class, we were able to graduate the first female woman interventional radiologist in Tanzania, obviously, Aza, who is like amazing. And 3 of us on this call are women in IR, women in medicine, in a place like the United States where there's much more freedom and things that we don't think we have to overcome. So I want to just, plant this now in a different place, a culture of being this first woman interventional radiologist in a country that they never saw that before, in a culture that is a little bit different, right? So we applaud Aza so much. So Aza is a part of the first class. In the second class, we graduated 2 women, Latifa and Fonzie. Fonzie is back in Nigeria, and Latifa is there now. And in the third class, we have Morvana, right? Another woman. And in the fourth class here, we also have a woman who is from Nigeria. So it is important that we are planting the things that we know are also important, right? That women are counted and that we're training people that are also able to go back to other parts of Eastern Africa, because this is the road to IR, right? Roads evolve. And like I say, with all other roads, right? They're bumpy roads. They're sometimes that you get to what would seem to be the end of the road, and you just have to decide, are you going left or right? And there are many times on this road that we just had to build the rest of the road as we're going, right? But no matter what, who walks with you on this road is crucial. And I'm reminded of the African proverb that says that if you want to go fast, no, say it, Judy.
No.
No. If you want to
You're
go
speaking too
fast,
much, Dr. Newsom.
Okay, I'm going to stop now.
No.
I'm going to stop now.
I want to hear it.
She's going to edit it out. This is not going to be
No,
on the thing.
we're
We're going to
not.
edit it out, right?
No, this is going to be voiceover. Please tell
Right.
me the
If-
African proverb.
Yeah, it says that if you want to go fast, you
Go
can
alone.
go alone. But if you want to go far, you must go together. And this is the road of going far, not fast. That this is a road that is being built to go far. And it is because of that as our central core that we know that it requires this collaboration. And with this collaboration is intentional diversity.
And
I'm so glad that you
No
mentioned
hallelujahs,
that.
by the way.
I just want to add here, it's like, to me, there's nothing more exciting than getting messages from now northern Tanzania, where we have Ziad in Mwanza saying he just did his first PIC.
Yes.
He just did his first nephrostomy. And,
Yes.
it's just, there's nothing better than that. Or Fonzie messaging from Nigeria. Yeah, she just did her first nephrostomy. She did her first abscess drainage. It's really, it gives me such happiness, and it's so exciting to see. And as Janice was saying, now the idea is really to also support those trainees that graduated from the program that now have the task of, by themselves, in some cases, really building training programs or IR services from the ground up. So, it all starts over basically from scratch, but not quite from scratch, because now there's a big family that tries to support them. And we're hoping that all of these programs will grow into training programs of their own and generate even more interventional radiologists.
I was raising my hand because I know that we're talking about these sometimes as just single procedures, but Dr. Isabel, when you go, you'll see that attached to every one of these, and I know you know this, are just the incredible stories of the patients for which a PIC is required or for which an abscess drain is required, and the Lazarus procedure of just placement of a nephrostomy tube, and how a simple thing, as we would call it, done every day, several times a day in the Emory system, that how a nephrostomy tube is able to actually save someone's life, like literally. And so, yes, when Fabian says, it brings him such joy to get this text, it's not that it's the joy of the PIC, right? It's the patient story that goes beyond that, and the life, not just sometimes of the patient, but of a whole family that is made different because of a small thing that we would do.
I think that's the magic of IR, right? That's what compels us, that's what I hear, Judy, when you talk come through your voice. Like, you just light up, when we were talking in Atlanta and you were telling these stories and and I watched you work. I mean, it's the passion I hear in Fabian, where we have to tell him to back away from the mic because he keeps leaning in because he wants to just eat it up. And Janice, where everybody's telling you that you're talking too much, and I'm like, talk more, because this magic is because we have the benefit to be in a field that we are still in love with. It's like a marriage where we're not in this phase where we're kind of sleeping in separate beds and don't want to engage. We're passionately in love with IR, and and it comes through. And you guys, you've done so many things right. You've collected data, you've published, you've formed this vibrant and engaging community that blows up my WhatsApp every day. You've sought to support the support of grants and of industry. And, as practicing IRs, many people might wonder how you have the time to do all of this work. So, I think there are going to be people listening who might want to emulate you. I hope they do. So I want to ask, do you have protected time, or is it like me and the II? Is this your passion project?
Well, it's actually a really difficult thing to answer just because of how we're paid. Most of us have to use their vacation time to participate. And maybe this is one of our biggest sort of next big step about sustainability and making sure we don't lapse into mission work. We know quite a lot of people actually do pay for their flights and, their expenses, and, would say that they would do it again. We've also been lucky also to get support of many industry partners too. And I would say that it's just so refilling, like this 1 week you spend there or 2 weeks it tops up your tank. And so if this is something, not because you're going to save Africa, I know that I'm notorious for posting some of those videos, but it really is for you too, when you go and you just have this amazing time and making an impact. But the impact here is tangible because just like Dr. Newsome said, every story, every patient, every procedure that you do has this story that there are not so many people trying to get the patient to you. You're taking care of that. And that, I think, just brings up a lot of reward. If you're that type of person, then you're of the IR tribe and you will absolutely enjoy it. So, it's really a call, to the academic institutions. As you know, most IRs, even in the university, are, bypassed when it comes to promotion to specific jobs, because the way departments make money is for you to be practicing IR and for you to be practicing IR in the US, taking care of patients, doing Y90s. But we, as a specialty, are so restless, and we want these amazing procedures that we do to be available for everyone. And so we make a way, and we've seen that we can make a way. And hopefully, as we think about the next phase and as we start new programs and learn from our mistakes, we don't want Fabian to be booking tickets through the whole night. We want to make sure that we create a safe environment that is sustainable, that is really driven by the needs of the local patients and the local attendings there who say this is what we need support with, and for us to evolve how to make sure that that is sustainable.
Yeah, so timing is a lot, and Fabian will make that word, because when he was a resident, I bet he thought, oh, I can take off all the time and I can go anytime I want, right? But as an attending, things are different. So you're right. Over the last few years, I have used my vacation, wisely, I would say. And Dr. Newton, you'll see when you go, and anyone who hears this that is gone, whether they're a nurse, a tech, a medical student, or faculty, they know that they leave feeling that they gained way more than they gave. And it is this, I know, counts in a part of my wellness package for myself, right? That, yes, I'm going to do the oral exam, but I know that when I'm on my way back, this deeper appreciation for this magic of interventional radiology, this magic of modern medicine, what I call better medicine, that we sometimes just lose it, as you say, in the mundane type of day-to-day work. But if you actually got to a place where someone says, wow, you're doing a pick, I can't wait to watch you do that, or I can't believe that, you think that you actually are talking to, 8 people in a room, and you turn around and there are 80 people in a room. And that type of environment just reinvigorates you. It reminds you why you chose medicine to begin with. I love when I see even the medical students that are coming from the US and they interact with the students there. And I want to plug this in, and I know that you will be able to, Dr. Isabel, say this, much better in the film, and is that we work hard. There's no doubt about it. But we also play hard, and there's no doubt about it. Okay. So if you go, you'll see that we have built that in as well, that the type of things that exhaust us in the United States, it's not the day-to-day work. It's not the things that bring the passion that you're hearing in our voice, the exhaustion from the U.S. experience, or, it's from some of the other things that just is not there. And that's how you're able to do it without dedicated time, without pay. You'll find a way. Fabian?
Yeah, as was said, when we started this, I was just a resident and I had some time on my hands. I was actually expecting when I become faculty, I'm going to have much more time, even though people told me that's not the case. And indeed, people were right. So I don't know how it happens, but yeah, finding time now is much more difficult than when I was a resident. And it's really only possible because of the big community that we have now. So there's so many people doing different aspects of this. Logistics is one part where I'm most involved, but then, we have Janice leading the actual educational portion. We have Jessica who's helping with coordinating equipment shipments. We, of course, have all of the now faculty in Tanzania now taking over a lot of the aspects that, were handled by myself or by Janice in the beginning. So it's really just about teamwork and about communication. And that's, I think, VJ leading the research portion. There's so many aspects of it, and, there are really too many people to mention, but it's really about communicating and about trying to help out where we can. And we all have limited time, but we try to invest it as best as we can.
That's really great. And I think, to Janice's point, when you fill your plate, and it may be a full plate, but when you fill it with things that give you joy, that inspire you, you may be full at the end, but you're happy. When you fill it with a bunch of things that are unpalatable, that you don't like to eat, even one of those things can make you nauseated. So all of us, I think, our common denominator is the fact that we all fill our plate very, very full, but it's stuff that we really want to delve into. I'd like to kind of shift and say, a lack of access to healthcare is particularly salient in East Africa, where resources are scarce. But there are regions of our own country and groups of Americans and residents who lack access to IR procedures. So what do you think we can take away from this experience to help bridge this gap back home?
I would say that this concept of reverse innovation is really what we can learn, what's worked there, and how to do it better here. I think one of the things that we've done is rethinking about the simulation and how to remotely support people when they're away. So I know that Dr. Newsome had to part with her camera, at some point, so that, and also understanding how do you explain to the local administrators, the patients, right, that they're not being watched, and especially, everyone is very cautious, when you're sick.
You're talking about a VR camera, right?
Yeah. We've gone, there are some VR cameras there. We don't use them as much, but there's even just a 2D camera that allows a wide span of the room, and figuring out logistically how to do that. At Emory, we do invest quite a lot in this tele-support of cases. I know every one of us has emailed a case to a colleague to get feedback on. So that's been one of the things. The second one, myself and Dr. Newsome are just about to go to Rwanda, is rethinking how to support the IT infrastructure to be able to do research, to also be able to have longitudinal patient follow-up. And so I would say that it's really, we've lacked in terms of the burden of administrators, which I think is a big issue here in the US. You have a bloated service that, of people who are not really helping you take care of patients. But back sort of in Tanzania, we've picked sort of like what are the best things and avoided some of the things like turf wars, which is a big issue about bridging care where there's not enough people who can provide access, and trying to protect your turf, which we know is a big issue here. And also trying to do this phased approach. I can tell you that our first stories, which you remember me saying this, was you have to be so careful about when you're introducing a new program, how to build a service line, and how to make sure that you're not getting into trouble, which is what we teach our residents every day when you get started as an attending, being realistic. And we've had Dr. Prologo, and his mandate there was just to teach access. This is one of the world's best pain experts who could do amazing things, but what was required is to teach access at that point when he was there. And so having this dynamic understanding and embracing, and this is a very biased, of course, suggestion, embracing technology to make our lives a little easier, I think is one of the bigger takeaways that we can see.
So I think of what you're talking about, this global and local aspect, right? This terminology that I didn't really like at all. And now I find myself saying it quite a bit because it is what people ask us often is, all this energy that you guys spend trying to put together a training program, to bring IR and access in Africa when down the street, that is not there. What about that? And I'd say that my passion is exactly the same, is that if you believe that interventional radiology improves health and saves anyone's life, then you wouldn't just want to do it at Yale, and you wouldn't just want to do it in California, right? You'd want to do it everywhere. It's like the gospel of medicine in a sense, right? This is the good news that better medicine has arrived and you can actually prevent your patients from having the burden of anesthesia, which is sometimes in and of itself the death penalty for some procedures where it's been done. So it is that how do you spread the good news, the gospel? This is Easter time in the U.S. Judy, do not say hallelujah. See her, she's getting ready to say that. But as you are thinking of, this is our code word for Newsome, you're talking too much, is that even if you just think about how that is spread, is that sometimes, the prophet is not welcome in their own home, right? But you still have to spread this good news because it is not he who brings the good news. The news itself is good, right? We're just privileged to bring the good news. And if it's not as welcomed down the street, you will go take a ship, as it says in the Bible that Paul took a ship and was shipwrecked, bringing the gospel to different parts of the world, translate that. Judy, I see you laughing. You know that. I can see you, Fabian. But I don't have any other I don't know how else to explain it.
No,
but,
I love it.
But the truth is, Isabel, is that our passion is the same. We would do this down the street in Bakersfield, California, in Cartersville. I'm making up these names, by the way. Georgia, or wherever it is that this is needed, we would still do it. But nothing is more rewarding, even in your own home, than your children that are so grateful for this box toy that you give versus one that says, oh, really? This little box toy? It's two ways that this goes, but we are not going to stop wherever interventional radiology is needed or a minimal invasive procedure. And I don't like saying the word interventional radiology because it's not about our specialty, right? Whoever does this. If you are a pulmonologist and, I'd like for it to remain in the house of IR, but, it takes a village. There's no shortage of people that need image-guided procedures. Like we are here to put the structure in so that we can assure the quality so that when someone says that they're doing this to a population of people, that they're safe, and that I would allow that to happen to me. So you can't just say that, oh, I did this weekend course and I could do this. If whatever this Road2IR consortium can do to provide a structure of training and support to bring these services to anywhere that it is needed, we would do it.
It's really the words of Desmond Tutu. he said that when the missionaries came to Africa, they had the Bible and we had the land. And they said, let us pray. We closed our eyes. When we opened them, we had the Bible and they had the land. And so my always north is to really be very conscientious, to listen to the doctors who are on the ground and what they think they are, and not, let's say, Tanzania mentality. And I have to say that just by extension, I saw this in this recent Ebola outbreak when the local Tanzanian attendings were trying to prepare the new program in Uganda and, still going back to the same COVID restrictions and wondering, how do we protect the faculty from the US? And they said, we're fine. Bring the Ugandan team. And that to me was just a big turnaround point, showing that, the mission is there and, we've made our impact.
Both of you are just that was so beautifully stated. Fabian, would you like to follow that up with any rich comment?
Yeah, no, just
Fabian,
coming
is the word.
Rich, Fabian, rich.
No, but just coming back to a question like, what can we learn from there? I think it's really having an open mind and open heart and reaching out to patients and to physicians. And that's something that there it was so obvious because there was no IR. So obviously we had to go talk to the surgeons, talk to the nephrologist, talk to the emergency physicians, explain to them really what is IR, what can we add. Same thing with reaching out to patients in Tanzania, saying we can do uterine fibroid embolization through the wrist. You don't need to have an open surgery. You don't need to have a hysterectomy. The same thing here. Like we kind of assume because we went through all the training that everyone should know what IR is. At least every doctor should know what IR is. But it's just not the case, right? So we really need to do more outreach to the community. We need to tell patients what we can do. We need to explain to other physicians what we can do, because we can really add so much. And it's really a lost opportunity if patients and other physicians don't know about our capacities.
That's so well spoken. And
amen.
Yeah, and
Hallelujah.
really,
That's a rich comment, Fabian.
yeah. And I think it really underscores why the collaboration between the Interventional Initiative and Road2IR is so natural. We both value improving access to minimally invasive image-guided procedures, which, as Dr. Newsome said, we are agnostic. It's not just about IR. It's about minimally invasive, which means we get patients back to their normal lives faster with less morbidity, less mortality. We keep them whole, right? And that's what life is about. It's not about being sick. It's about living your life. And that's what the magic of IR is. We enable patients to do that. So I'm really grateful to all of you for this really amazing opportunity to speak with you. My colleagues in the Interventional Initiative and I are very much looking forward to our first trip to Tanzania in May. We at the II are grateful to Boston Scientific and to Varian for significant grant funding that will support our filming of Without a Scalpel, which will at least be episode 5, but may actually be a feature-length documentary. We're also grateful to Doximity for supporting our travel, and they've been supporting the travel, I think, for a lot of these docs who are going to, to Tanzania and to East Africa. And we just hope this is just the beginning of an enduring collaboration between the II and Road2IR. And I'd also like to take this opportunity to thank BackTable for their collaboration. We are huge fans, and we think you're doing a great service to our field. And thanks for this chance to touch base with the Road2IR team, or at least a part of them, and find out all the exciting things that you're doing. So thank you.
Thank you, Dr. Newton.
Thank you.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Don,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
article and transcript support by Taylor Robinson
and Delaney Aguilar.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.